Botulism. Botulism is poisoning caused by toxins produced by Clostridium botulinum, which is an anaerobic bacteria. Most common cases of botulism arise from contaminated food being served undercooked. Pathology of botulism. Botulism occurs from absorption of the toxin through a mucosal surface, with intestinal absorption being much more common than lung or wound intoxication. Next, after absorption, the botulinum toxin blocks the release of acetylcholine at the presynaptic level. This results in blockage at the neuromuscular junction, postganglionic parasympathetic terminals, and autonomic ganglia. Classification of botulism. The first type is foodborne botulism. It occurs due to ingestion of preformed toxin in contaminated food. It is the most common form of botulism. Secondly, we have wound botulism. It develops from the toxins produced by infection of a wound. Thirdly, infantile botulism results from ingestion of spores which on germination in the gut produces toxin. And fourthly, we have inhalational botulism which may occur due to release of aerosolized spores. Clinical features. Initial presentation includes gastrointestinal symptoms followed by involvement of cranial nerves causing diplopia, dysphagia and dysarthria. Diplopia means double vision, dysphagia is difficulty in swallowing and dysarthria is difficulty in speaking articulated words. This is followed by descending motor paralysis and then diaphragmatic paralysis and death. Parasympathetic dysfunction may occur occasionally, which produces dry mouth, dilated non-reactive pupils. Fever is absent, though mild drowsiness is present. Infant botulism is characterized by the onset of constipation followed by weakness in sucking, crying or swallowing. This is followed by progressive bulbar and extremity muscle weakness. Investigations. Diagnosis of botulism is based on clinical features. Toxin can be demonstrated in blood in case of foodborne botulism or stools in case of infantile botulism. Culture for organisms are taken from the wound. Includes supportive care with assisted ventilation, prevention of secondary infection and administration of equine heptavalent botulinum antitoxin or human botulinum immune globulin.